Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher, and today is October 29th, the last Tuesday of the month, and you know what that means? That means that we are at Top 10 Tuesday. So this is my segment where I bring you the top 10 Coding Corner questions I've had for the month, and some of you have asked me about that. What is the Coding Corner? And what that is it's an on-demand membership where you can join from going to my website, going under services, it's the first one listed, and if you have coding questions or billing questions, or you need something troubleshooted, or if you're having trouble, wording an appeal for a claim, then we can help you. And it is a paid membership, so it is $1,200 a year for unlimited coding questions and billing questions and anything that you need. One thing I did want to clarify, because we have had a couple of recent membership signups, which we appreciate, but just making sure you're aware, we are not your claim scrubber. So somebody had recently signed up and then sent me every single one of their claims and with reports saying, can you review these to make sure we're billing this out correctly? Can you make sure? And that's not what we do. So if you have a question about something, or you're saying, I billed this out and I got a denial, or the doctor sent me over this and I came up with 2 codes, but I think I need more codes. Can you just take a quick look? Or we need help with an appeal letter, or I heard this regulation came out on billing. Or can you tell me what my doctor needs to document to be able to record or report an EKG? Something like that. That's what we're here for. So it's really a troubleshooting service. If you ever run into trouble, here we are. So we can help you with that. But it's just nice to have somebody that you have on retainer if you ever run into some issues that you need clarified. Okay, so let's get into what we're going to cover today. We have a lot of information. It's been a big month for breaking news. I hope everyone also is liking your weather right now, because right now in California, Southern California, it is 97 degrees. And I was in Colorado on business only 4 days ago, and it was 36 and snow flurries. So those of you that say there's no global warming, okay, whatever. I don't believe you, because it has been all over the place. So hopefully wherever you are, you're enjoying some fall weather and able to listen to the Codecast comfortably today. But first, today's Codecast is also brought to you by Kaiser Permanente of Southern California, promoting Breast Cancer Awareness Month and encouraging everyone to wear pink to work in the month of October. Find them on the web at kp.org. And Inc. Magazine, everything you need to know to start and grow your business now, inc.com. Okay, so let's see what we're going to talk about today. Boy, have I had a lot of coding questions and billing questions and just questions. It's just crazy. So one of my first ones comes from South Dakota. And just so you know, I mentioned the Coding Corner membership. I have people and members from all over the country. So as far as you can get east, I guess would be West Virginia, all the way as far as you can get west here in Southern California, down in Texas, you name the state, we've got somebody represented there. So hopefully, if you feel that you need this service, you'll join. So the first one says, how would you handle the notes that have enough documentation to support a higher level than what the presenting problem is worth? Example, excessive documentation for a history of present illness, so the HPI, exam, and the medical decision-making is low or straightforward. Technically, it qualifies for a level 4. However, example, the patient came in for a nosebleed and it doesn't need such a high level HPI or an exam. How would you agree with the physician that coded 99213 or audit as 99214 since 2 out of 3 components are met? I'd appreciate your thoughts because I'm getting conflicting information. So you're going to continue to get conflicting information on this only because when you audit a record, it's a score sheet. And when somebody presents, whether it be appropriate or not, to be able to give the physician the right to move forward with the documentation that they populate each field, it's a score sheet. And if they score it a certain way, then some auditors out there will say this is a level 4 no matter what. Well, you'll notice in the Social Security Act and also in the Medicare guidelines, it says that medical decision-making is one of the overarching components to making sure that your code is supported. And I also, like you, want to see that the presenting problem was worth going into a full-blown comprehensive exam. Now, the problem you're going to have is now you're borderline questioning a physician's judgment. So if a patient comes in, like you said, for the nosebleed, did they have the right to go into a full-blown HPI, a full exam for different body parts or different systems? And then what is that medical decision-making for that presenting problem? What I try to do is really just start with education and let the physician know that technically you may have a level 4 here, but you may have an auditor or Medicare may see a pattern and may come back and take that away from you. And I'm pretty strict with my clients that I audit for on retainer, where they have me audit every day or every quarter, every month. They're physicians, and I do retro audits and also level 5 audits before they even walk out the door, because I want to make sure that they are audit proof. And so you can basically do one or two ways. You can basically say, okay, well, this scored at this amount, but based on this presenting problem, you may have trouble getting this reimbursed, or it could be questioned in the future. And if you're not a clinician, so if you don't have RN, NP, PA after your name, as a coder, it's really hard to question the physician's judgment. So stick to what is populated, stick to what is on your score sheet, and then talk to your physicians about that, because then you can get into trouble. So number 2 says, Terry, when is the for sure date that ICD-10-CM is coming out, and where can I order my book, and how soon? Okay, so ICD-11 is coming, and the World Health Organization and Centers for Disease Control have a final date where it will be coming out January 1st, 2022. So just a couple of years, not very far away. And here's the thing I don't like. We're not going to have a book for that year. They've decided that the book would be too big. Look at your ICD-10 book. And for those of you that don't know what ICD-11 is, ICD is the International Classification of Diseases. So this is our diagnosis book. We're currently in the 10th revision, modification, I should say. And because that's the CM, clinical modification. This is for physicians. But I like my book. So this is going to be a hard thing to have. They're only going to put it online in PDF form and downloaded spreadsheets. So I don't like not having a book. A book is like my coding Bible, and I like to be able to reference it whenever I can. So I definitely have a problem with that. But that is the target date. So January 1st of 2022. Number 3, definition of morbidity and mortality. Now you'll see this on risk table as well when you're dealing with E&M services, but this is also part of the diagnosis general guidelines. And a lot of coders don't know the simple definitions of these two terms. So somebody asked me, Terry, can you clarify the definition of these two terms? So morbidity, that is the state of being diseased or unhealthy within a particular population and severity of that illness. Mortality is the number of people who died within a specific population. So for example, mortality rate for a certain disease. So just know the difference between those two services. Now, number four is SDOH. Somebody said, I'm seeing this acronym everywhere. S is in Sam, D is in donut, O is in ostrich, and H is in house. What are those? Well, according to the Centers for Disease Control, social determinants of health. Okay, so that's what that acronym stands for. These are societal and environmental conditions such as food, housing, transportation, education, experiences, social support, and employment that can affect a person's health. So there's been numerous studies that have demonstrated a link between economic status, social factors, and physical environment as key influencers in health outcomes. So the SDOH codes are represented in ICD-10-CM, and they're in the categories Z55 to Z65, and they describe conditions such as poverty, homelessness, abuse, neglect, etc. And payers sometimes do deny these because you can't code them as a primary diagnosis, but they should be included as a secondary diagnosis if you can, because hospitals across the United States are filled with patients that have some kind of a social determinant of health as part of their patient profile. So, for example, and I'm actually borrowing a line from an article that was given to me by Tony Elholmes, one of our podcast listeners and also very up-and-coming consultant. And I really like this article because the information she gave was pretty much a challenge to coders to really understand what SDOH is. So her example was a homeless man is admitted to the observation unit for chest pain of an unknown origin. After a comprehensive workup, there's no medical diagnosis concluded and the patient is discharged. A secondary diagnosis would be helpful to give a complete health picture and profile of this patient. And so it just gives some information that may determine, can they get access to care? Is there a reason why they're not getting better? Do they have access to medications, etc.? So take a look at those if you can. And again, category Z55 to Z65. And they do describe those conditions that are really societal and environmental conditions. So I appreciate that question. Number 5, we had someone inform one of our physicians that when we have a pacemaker clinic in the office, either the physician or the nurse practitioner can go in and see the patient, and we can bill for a visit along with a pacemaker check. I believe we can only bill for an office visit if there's a medically necessary reason for us to see the patient. Please, can you let me know your thoughts on this, Terry, because I'm concerned here. Okay, so this is one from one of my subscribers in Pennsylvania. Yeah, it's funny because I don't know where sometimes people get these ideas of saying, just, you can do this, guess what you can do, without having backup that you can actually provide the service. And so you are correct. Unless there's a medically necessary reason above and beyond that device check, there's no reason to have an office visit. And let me clarify. There may be patients who have atrial fibrillation or sick sinus syndrome or some kind of tachycardia. The reason that they have that pacemaker, they have an abnormality in the computer of the heart. And let's just say that they also have another diagnosis that is hypertension or hyperlipidemia, high cholesterol, or something else. Unless there is a problem with that second diagnosis that is unrelated to the device, and there needs to be some kind of an adjustment or modification or change in med or treatment or something like that, then again, there is no reason for a visit. Just pulling a different diagnosis is not medically indicated. So be careful with that. It was a good question. I'm glad you brought it to my attention because I see that all the time and it's just not appropriate. Okay, so number 6 says our doctors cover the hospital ER and follow the patients throughout their stay, but recently the hospital hired their own nurse practitioner and they help round on patients. Most of the work that I am seeing them do is discharging patients. If the hospital employs them and we co-sign their charts but are not seeing the patient upon discharge, can we bill for the NP's work? And does this change if the doctor stops in and sees the patient but the NP is doing the actual charge? Well, I bet everybody on the call or most of you can answer this. So there's no such thing as incident 2 in the hospital or facility setting. And that was last week's podcast. And so no, you can't share in anything of the NP's work. And remember, there has to be an employment relationship with the physician and that mid-level provider to be able to include anything, even as far as a shared visit. So if you have a hospital mid-level provider, nurse practitioner, PA that's doing the work because the hospital employs them, then that's just on them. They're the only ones that can actually capture that service. It's like the hospitals that employ hospitalists. Your physician can't use any of their documentation or their information and include it in their own documentation and then bill it out for whatever level of service that is. So please have them stop doing that. That is absolutely incorrect, and you'll find that on audit you would get into big trouble with that. Okay, number 7. Good morning, Terry. Last night, our physician went to a physician talk at a university, California, San Diego, where another physician was presenting. And this physician that was presenting told the attendees that if you're an interventional MD with the C3 classification, so this would be an interventional cardiologist, you should receive payment from a consult or a new patient visit if a fellow non-invasive MD cardiologist in our group sends them to him for catheterization decision. First of all, I'm sure it's for Medicare patients only, right? Also, you explained in our meeting that our non-invasive cardiologist has the ability to determine that they need a catheterization, and it's not okay to bill this as a new consult. Of course, the presenting doctor at this talk told our physician that they're making all kinds of money doing that. Of course they are. Please tell us what you think, because you know our lead physician only listens to you. Okay. Well, I appreciate that, by the way. But here's the thing, and I've talked about this before, not just in consults, but where you need to be cautioned about certain things that you do. And always remember, just because you can doesn't mean you should. So what that physician was basically referring to is there are different taxonomy codes which identify physicians of different specialty within the Medicare system. Interventional cardiology got a new taxonomy code a couple of years ago, C3, and it's a 2-digit code, but most taxonomy codes are not alphanumeric. This is because it's being tracked right now. But you have to know the intent of the physician, the original physician that felt that they needed to transfer the patient to the interventional cardiologist. So if the heart cath physician went ahead and did a cardiac catheterization, but they don't do interventions anymore. And did you hear what I said about that? Anymore. A doctor who they call non-invasive usually stays in the office and just does testing in the office. But there's an occasional non-invasive cardiologist who will do caths, but they'll transfer the patient for a PCI or a percutaneous coronary intervention, so a stent or an atherectomy or an angioplasty, to an interventional cardiologist. And the thing is that it's not that they're transferring them because the cath doctor or non-invasive physician doesn't know what the patient needs. They just don't do it anymore. They decided they wanted a lifestyle change. They want to work 8 to 5. They don't want to be on call. They don't want to be called over and procedure scheduled late. And so they are now considered non-invasive. That is not asking another physician's opinion whether or not they're making a cath decision. That's transferring the care. And in my professional opinion, I would never code first you can't code a consult with Medicare because they don't recognize those codes, but never code a new patient visit, which I'm sure that's what the physician was alluding to in this scenario, because it's not appropriate. They're not now taking a new history, a new HPI, doing a new exam, performing medical decision that wasn't already done. And so to me, that is absolutely out of line. And if they're making money doing that, it's inappropriate and they're going to get caught eventually. So that would not be appropriate in my opinion. Number 8. So this question actually comes up a lot. And this is with the hierarchical condition category codes, so HCCs, under risk adjustment. And what that is these codes and their diagnosis codes, they estimate future healthcare costs for patients under the Medicare replacement plans. So a question comes up, and this is actually from one of my Texas clients: is an undated, unsigned problem list acceptable documentation of a diagnosis to support capturing HCC codes if the progress notes refer to the list in the medical record? And I'm talking about an inpatient hospital coding. So plans should use the progress notes as documentation to support the diagnosis instead of a problem list. Problem lists can include any and every type of condition for a person, regardless whether the beneficiary received services for the conditions during the data collection period or not, and are not acceptable standalone documentation tools. So there are certain things that HCCs require. First of all, face-to-face encounters. So coding from a problem list when there is no corresponding face-to-face encounter is not acceptable. Second, encounter documentation must reference the diagnosis to achieve the MEAT requirements, MEAT. That means monitor, evaluate, assess, address, and treat. So a problem list alone will not do that. To make sure you're complete in your documentation efforts for HCC coding, you have to monitor, which means signs, symptoms, disease progression, disease regression. You're not going to find that in a list. Evaluate, so that means test results, medication effectiveness, response to treatment. Assess, address, ordering tests, discussion, review of records, counseling, and then treat, what medications, therapies, or other modalities. So pulling a problem list into the encounters documentation that does not specifically address each of the conditions on this list in the extent of the MEAT, they call it, is not sufficient. So a problem list may reflect conditions that are no longer pertinent or active, and pulling that list into the encounter, you're going to have some errors. So I would absolutely say that would be incorrect as far as using that to capture your HCCs. Okay, question number 9, and this one's interesting because I had to do some research on this one. Says, Terry, I have a question. I listened to your podcast. I hope you can answer this quick, and we're going to be joining your service. Thank you. Says, how private is your health data on patient portal websites used by hospitals and doctors' offices? Patients are starting to complain that they're getting some marketing information. So I know exactly what they're talking about. Think about when you make an airline reservation or a hotel reservation, or you buy something online, then what happens? All of a sudden, every time now you pull up your computer, if you're on the internet, you get ads for this because it takes that information. It's kind of like somebody stalking you, takes that information and now determines what you may want to see. So when you're getting on or the patient's getting on a patient portal, it's not as private as you might hope it is. And when you think of HIPAA, this is the Health Insurance Portability and Accountability Act, privacy. You would think that patient portals should fall under HIPAA and there shouldn't be an issue. But a member of my Coding Corner membership who asked me not to use her name emailed me after reading the privacy policy in an external website used by her doctors at George Washington University Medical Faculty Associates. The patient portal, followmyhealth.com, reserves the right to use personal health record data for marketing and advertising purposes, including sending you marketing and advertising communications, whether on our behalf or on behalf of marketing partners. Okay, I was like, what? What are you talking about? No one wants to see their medical diagnoses turned into an ad. She also noted that when she logged into Follow My Health, she couldn't find any privacy or data sharing controls, basically a way to opt out. And the only way to prevent the use of the data for marketing appears to be canceling or deleting her account. So I tried to figure out, okay, let me dive into this a little bit further. What is the law here? So a patient portal that has a business associate agreement with your doctor's office, and make sure you have one. Some doctors forget to get that. They have one. It says to collect your personal health information. It should be covered by HIPAA. The U.S. Department of Health and Human Services says, but under HIPAA, showing paid targeted advertisements should require consent from each patient. I also contacted the parent company of the Follow My Health corporate parent, which was Allscripts. It painted a little bit narrower picture of its practices and claimed the site wasn't limited by HIPAA. I was like, okay, explain this to me. So the company's director of marketing communication said the site is, quote, not disclosing identifiable patient data to third parties for any marketing purpose, even though the wording on the site said its privacy policy specifically reserves the right to release personal health data for marketing and advertising. Now, they have since updated the policy to take out personal, but he said Follow My Health is using information about patients to alert them to goods and services that could support their ability to make more informed choices about their own care. And all of this happens inside the Follow My Health website. He says, we have discussed the possibility of alerting patients to inform them about medical research opportunities, clinical trials, or insurance plans that could be relevant. But here's the head scratcher for me. Follow My Health claims is not limited by HIPAA. Unlike a patient portal that a vendor hosts or supports for a single healthcare provider, a vendor of a personal health record product that allows individual consumers to aggregate their health information from multiple sources is not regulated by HIPAA. Because again, under the business associate relationship, it's limited to the technical work that is necessary to establish and maintain a connectivity between a doctor's electronic system and Follow My Health. So for example, when I remote audit for a practice, I'm covered under HIPAA because it's the connectivity. I'm basically accessing a record between myself and a physician's record and patient record. But here's a broader HIPAA concern to me. There's a misconception that all health information is protected by HIPAA, and that's just not true. So there's a growing number of apps and websites that skirt oversight, such as wearable devices that can track your heart rate, or an app or portal where individuals can store their own health information. And if a company isn't covered by HIPAA, it can do more with your health information than you might think, and without, your consent or the patient's consent. So here's the takeaway here. Yes, you should be suspicious of health portals, even if your personal doctor uses them. There has to be a way a patient can choose to opt out from marketing without having to delete their account. And we should demand doctors be more careful about who they do business with, especially with the new rules on the guilt by association regulation that's going to be effective on November 4th. That's my next podcast, by the way, on November 5th. And so you can lose your Medicare reporting ability if they're affiliated with any company who has violated Medicare policies in the past. So I love this question because you definitely want to be proactive if you are going to now enlist a patient portal, which I strongly recommend. Patients need to be able to access limited records. They need to be able to pay their bill online, etc., but are using this information for marketing purposes and it gets leaked or somebody gets a hold of this information without the patient's knowledge, you're running into a lot of HIPAA violations and just some headaches for the patient. So really be mindful of that. Number 10, official diagnosis coding guidance for 2019. So Terry, we're having a lot of patients that have e-cigarette issues or vaping issues and some lung injuries with relating to vaping. Are there any diagnoses that we can use at this point? Okay, so October 17th, the World Health Organization and the Centers for Disease Control came up with some supplement coding information that's really helpful. They call it EVALI. EVALI is the acronym because there's been some deaths and obviously injuries associated with, and this is the acronym, e-cigarette or vaping product use associated lung injury. That's the EVALI, e-vaping associated lung injury. They released on October 17th. So they're going to come with some more specific codes next year. But for right now, it says supplement coding encounters related to e-cigarette or vaping product use. And this is how you do it. So with patients documented with this problem, you're going to assign the code for the specific condition. So for patients with acute lung injury, but without further documentation identifying a specific condition, assign code J68.9, unspecified respiratory condition due to chemicals, gases, fumes, and vapors. For children and adults who have been poisoned by swallowing, breathing, or absorbing cigarette liquid through their skin or eyes, assign T65.291, and you'll need a seventh digit for encounter. Is it initial encounter, subsequent, or sequela? And that is toxic effect of other tobacco and nicotine, accidental, unintentional. And that this includes a toxic effect. For patients diagnosed with acute THC toxicity, assign the code T40.7X1 and a seventh digit, and that's poisoning by cannabis derivatives, accidental, unintentional. The seventh digit is required. And for patients with documented substance abuse or dependence, additional codes identifying the substances should be assigned as such. So if both use and abuse are documented, assign only the code for abuse. If both abuse and dependence are documented, you're only going to assign for dependence. If use, abuse, and dependence are documented, again, just dependence. And you also need to include the nicotine dependence or other tobacco product, F17.29, and a sixth digit is required on that. If both use and dependence are documented, assign only the dependence. So for patients with any symptoms of EVALI and where definitive diagnosis has not been established, you're going to code this sign or symptom. So they have chronic cough, if they have, difficulty breathing, etc., or any kind of burns. And I think this is important because right now I do a lot of work with smoking cessation and trying to get physicians to capture that service. And you can't capture it for patients who abuse or vape or abuse e-cigarettes or anything that it's not tobacco related. So we're even having patients that are having an issue with the cannabis reaction. And that's, the thing with vaping and e-cigarettes, and talk about ironic, those are considered tools as smoking cessation tools. And now it's become a huge problem. And don't even get me started on the vaping that has blown up somebody's hand because of using it incorrectly. So it just, and I say using it incorrectly loosely because the use of it is just so rampant and terrible right now. But hopefully that gives you some insight on that coding opportunity because we haven't had any in the past. And so that was retroactive to October 1st. So I can tell that this is an important topic because today our coding question number 10 was brought to you by SiriusXM Radio, Dr. Radio, channel 110. Check it out live and on demand. Download the SiriusXM app today. So they wanted that question on there, and I want to make sure that we did do it justice. So today I'm going to end with my personal insight this week, and actually it's about skincare. So for those of you that have met me or know me or have ever seen me in person, you probably know, or maybe you don't, that I do not wear makeup. I never have. It just isn't me. And my friends wear it. Everybody wears it except me. I tried a long time ago as a teenager and even a young adult, and I could feel it, and I just don't get it, with the exception of my Dr. Pepper lip smacker. Well, today I have Sprite lip smacker in my pocket. It's just, I don't wear makeup. So, but I still pay a lot of attention to care of my skin and self-care and different things like that. And living in Southern California, and all the travel that I do, I have to really take care of that. So I was having breakfast with a friend recently, and she looked at me and she's like, "Your skin looks amazing. What do you do to keep it that way?" And for somebody that just turned 50-ish, I'm just going to leave it there. And living in California, like I said, and I was just in Colorado, I mentioned earlier, it just can dry out. So I use a product called Murad, M-U-R-A-D, and it's Murad Nutrient Charged Water Gel. And just a little goes a long way. And you can Google it, and it's not too expensive. I just use a little at night and a little in the morning, and it just keeps my face and neck looking hydrated. Apparently I have a nice glow and hopefully looking younger than I am. But it was such a nice compliment. So thank you, Dina. I thought I would share with you. So somebody had asked me that a couple of times before, and I was like, wow, that is really a nice compliment. So apparently I'm doing something right. But the travel size lasted 4 months. So if you just want to try it, a little tip, if you live in a dry climate, and now with fall and cold weather coming, it may be something you want to give a try. So anyway, that's for this week. It's just my thoughts for today. Hopefully you enjoyed the Top 10 Tuesday. And on this Terry Tuesday, we're going to call it a day. So everyone go out and make it a great day, a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.